الفاتحة. أعوذ بالله السميع العليم من الشيطان الرجيم. بسم الله الرحمن الرحيم. الحمد لله رب العالمين حمدا يوافي نعمه ويكافئ مزيده. يا ربنا لك الحمد كما ينبغي لجلال وجهك الكريم وعظيم سلطانك. اللهم صل وسلم على سيدنا محمد صلاة تنجينا بها من جميع الأحوال والآفات وتقضي لنا بها جميع الحاجات وتطهرنا بها من جميع السيئات وترفعنا بها عندك على الدرجات وتبلغنا بها أقصى الغايات من جميع الخيرات في الحياة وبعد الممات وعلى آله وصحبه أجمعين. اللهم اجعل جمعنا هذا جمعا مرحوما وتفرقنا من بعد تفرقا معصوما ولا تجعل فينا ولا معنا شقيا ولا محروما يا أكرم الأكرمين. اللهم اغفر لنا ذنوبنا ولإخواننا الذين سبقونا بالإيمان ولا تجعل في قلوبنا غلا للذين آمنوا ربنا إنك رؤوف رحيم. Ya Allah, sesungguhnya kami berhimpun pada hari ini bagi melahirkan rasa kesyukuran di atas kurnia-Mu yang tidak ternilai. Jadikanlah kami hamba-hamba-Mu yang sentiasa bersyukur di atas nikmat yang melimpah ruah kepada kami. Ya Fattah, ya Alim, sesungguhnya Engkau maha mengetahui bahawa kami di sini ingin menimba ilmu-Mu yang sangat luas bagi mengembangkan posisi kami sebagai hamba-Mu yang Engkau ridai. Justru berkatilah dan rahmatilah perhimpunan kami ini. Kurniakanlah kepada kami apa kiranya ilmu-Mu. Sinarilah hati-hati kami dengan cahaya dan hidayah-Mu. Semoga dengannya kami mudah menerima dan menghayati serta mengamalkannya. Ya Zal Jalali wal Ikram. Allahumma innaka ta'lam anna hadhihi al-qulub qad ijtama'at ala mahabbatik wa altaqat ala ta'atik wa tawahadat ala da'atik wa ta'ahadat ala nusrati syari'atik fawathiq lahumma rabitataha wa dimuddaha wa diha subulaha wa amlaha binurika alladhi la yaqbu wa shrah suduraha bi faydal iman bik wa jamili tawakkuli alayk wa ahyiha bi ma'rifatik wa amis ala syarati fi sabilik innaka ni'mal mawla wa ni'mal nasir. اللهم آمين اللهم آمين اللهم آمين. ربنا آتنا في الدنيا حسنة وفي الآخرة حسنة وقنا عذاب النار. صلى الله على سيدنا محمد وعلى آله وصحبه وبارك وسلم والحمد لله رب العالمين.
Thank you, Dr. Ahmad Farhan. So, warm welcome to Grand CPC by the Department of Medicine. So, I'm Dr. Mohan and it's my pleasure to chair today's session. The title for today's CPC is In the Shadow of the Wild, the Cutis Deep Secret. And as the title hints, we will be unraveling a case where the skin actually has more than meets the eye. Okay, a complex journey that cuts across multiple specialties and demands a truly multidisciplinary approach. So among our panelists today, we have Dr. Izreena Ismail, Dermatology Fellow, who will be moderating this case and guiding Dr. Firhan, our Registrar in Internal Medicine, in exploring this case. Also, we have expert inputs from Dr. Ummu Afeera, ID Fellow from University Islam Antarabangsa, Dr. Hanani Ahmad, Clinical Microbiologist and Head of Microbiology Unit, Hospital Sungai Buloh, and Dr. Stephen Chu, Registrar in Histopathology. So without further delay, let's begin the session. I invite Dr. Izreena to start off.
All right. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh, and a very good morning to all the professors, consultants, specialists, fellow doctors, and also medical students. So indeed, Alhamdulillah, I'm very delighted to be here today, inshallah, to be sharing one of the fascinating and interesting cases that we have seen back in September 2023. So fortunately, I'm not alone today. So I have the pleasure of being accompanied by one of our best registrars in internal medicine, Dr. Firhan bin Hassan, with me today. So we'll journey through together to uncover the deep secret beneath the cutis, which is the skin. Right. Okay, so what we'll do now, I'll talk through the history, the brief history first, and subsequently followed by questions to Dr. Firhan. Okay? Okay, so this is Dr. Firhan bin Hassan, in case you don't know him. Right, okay, so the history. All right, okay, so the patient, we shall call her as Dr. JS. Dr. JS is a 45-year-old Malay woman. So she is previously and currently still working as a zoologist and lecturer at a public university. Right, so she has underlying grave disease with active thyroid eye disease, of which she received 6 cycles of high-dose intravenous methylprednisolone for 3 times at that point of time. So during the third time receiving intravenous methylprednisolone 500 milligram daily, that was sometime in September 2023, she appeared unwell with multiple joint pains and evolving rashes, of which that has actually prompted our ophthalmology colleagues to actually admit her to their ward for further investigation. So at that point of time, when all the subspecialties were actually referred to and involved in the management of the case. All right, just to breeze you through the chronological history. It's an extensive history, but I'll try to make it very simple for the purpose of this CPC. So she was referred to us at this point at about 11th of September 2023. So bringing you 2 months prior to that, on 27th of July, she basically had this onset of rash over bilateral forearms. And then about 3 weeks following that, she started to develop symmetrical joint pain over bilateral knees, of which she was prescribed with NSAID by the GP. And then 3 weeks after that, about 1 month after that, she started to have evolving progressive rash, now affecting bilateral lower limbs. So remember that she had the rash initially, late July over bilateral forearms, which did not resolve. Subsequently, she developed another rash at lower limbs. And then following that, she had this debilitating joint pain, now affecting wrists and ankles, of which hindering her daily activities, including her prayer. She couldn't rukuk or sujud because of that. She can't be doing her normal jobs like usual. So during this course, she has been prescribed with 2 courses of antibiotics, namely the cefuroxime and unacin, but none of the antibiotics has resulted in improvement of the skin lesions or the joint pain. All right, so a bit of the drug history for the grave disease and hyperthyroidism. She was on tab carbimazole 10 milligram daily. Unremarkable past surgical history. She has no allergy history of note. She is a single nulliparous woman. She's a non-smoker, non-alcoholic. Just to emphasize again to Dr. Firhan, she is working as a zoologist. Unremarkable family history. Other systemic review, including the central nervous system, respiratory, cardiovascular, gastrointestinal, were unremarkable. Okay. Right, moving on to the first question to Dr. Firhan. So based on the brief history that has been given to you, what sort of further history would you like to elicit from this lady?
Good morning. So this is quite a broad question, so allow me to maybe compartmentalize this into a few sections. So with regards to the main presenting complaint, which was initially the rashes, I would like to know a few details into this. So as elaborated earlier by Dr. Izreena, so the rashes have already started at the forearm, and then eventually later on in a few months, in a few weeks leading up to the presentation, have spread to the legs. I would like to know in nature of the rashes, whether it's itchy, whether it's painful, whether there's any intermittent resolution of the rashes, and also I would like to know whether there's any preceding, considering her nature of the work, whether there's any bite or any wound that precede these rashes. And then secondly, in relation to the joint pains, I would like to know whether the pattern of the pain, it seems like from the presentation that Dr. Izreena described, it appears to be of peripheral joints, but I would also like to know with regards to the onset, were there any involvement of the axial joints as well? And then moving forward to the next set of questions is any other related symptoms. So first of all, any general systemic symptoms? Sorry for the allowed time for prayers earlier. So moving on into the second section of the further history that we would like to know, which is related symptoms. So I would like to inquire whether there's any general symptoms like maybe perhaps associated fever, any constitutional symptoms like loss of weight, loss of appetite, and then moving from head to toe. So I would like to inquire whether there's any additional history of significant hair loss, or maybe presence of ulcers in the nose or in the mouth that could indicate symptoms of connective tissue disorder like lupus erythematosus. Other than that, I would also like to inquire whether there's any respiratory or cardiovascular symptoms like dyspnea, syncope, whether there's any progressive worsening dyspnea, persistent cough, and subsequently, I would also like to know about any other related symptoms, like for example, gastrointestinal symptom, whether there's any prolonged diarrhea, whether there's any alternating constipation that could point to more infectious diseases or any connective tissue disorder that is associated with inflammatory bowel diseases, and then moving on to the last or to the third section of the further history that I would like to ask is related to the nature of the work itself. She worked as a zoologist, so I would like to inquire whether there's any extensive travel history that the patient have, and also draw a timeline from this correlating to the onset of the symptoms. Lastly, I would also, on this section, I would like to know whether what type of specific animal, whether any mammals involved, rodents, or maybe poultry, and then whether there's any consumption of any unpasteurized milk, in this case, that could suggest infective causes. And lastly, would like to revisit again the medication history, whether there's any prior exposure to any antibiotic that could have caused the rashes as well. I think that.
All right. Okay. Excellent. Thank you very much, Dr. Firhan. So actually, he has covered, I think, 90% of, I think, the questions that we need to further ask. So this is sort of like the further history that I have put. I think he has taken almost all of it. So before I move into these details, so maybe I just answer the question that has been asked by Dr. Firhan earlier. So with regard to the rash, so it's actually a progressive rash. It's persisted. So meaning that the older rash, they are still there. They are painful but non-itchy. All right, painful but non-itchy, progressive. All right, for the past 2 months. Right. Okay. With regard to the joint pain was involving mainly the wrist ankle. The predominant is the bilateral knee. There's no axial involvement. There's no early morning stiffness. She never had this kind of joint pain prior to this. All right. Okay. I think another question is about systemic involvement. I think I mentioned earlier on. So it's good that you specifically ask for what sort of questions in the systemic review that you want to ask. But for this patient, she basically just had joint pain and rash. There's no other systemic involvement. All right. There's no fever as well. All right. There's no fever. And then I think you mentioned almost all of it. Okay, you did mention, I think you were saving the best for last. At the end of your description, you talk about the traveling history and contact with zoonotic animals, which I think is one of the most important things to actually ask in this patient. And don't also forget about your TB and leprosy contact, right? You know that TB, not only involving the pulmonary, right? So it can actually affect any part of the organs, and skin is one of the organs that can be affected with tuberculosis, and leprosy, don't forget as well. So you need to ask if the rash, was it associated with numbness, loss of sensation, etc. All right, and specifically the contact of TB or leprosy contact. So I think you correctly mentioned about the connective tissue disease symptoms. So there's no oral ulcer, there's no alopecia, hair loss, there's no photosensitive rash. Because these basically the demographic really fits, demographic for a connective tissue disease like systemic lupus erythematosus with positive autoimmune graft disease. So it's none. And I'm glad that you mentioned about detailed drug history, because I think almost 50% of referrals to the dermatology team is usually drug eruption, drug rash. So it's important for you to actually ask about the detailed drug history with timeline. For this patient, all the rash actually occurred even before initiation of the antibiotics or analgesia. Okay? So before I ask further question to Dr. Firhan, just to bring the audience through the world to see, the traveling history that patient had about 2 to 3 months prior to the onset of the rash. All right, so she visited Baltimore, Maryland, USA in May 2023. So that was about 2 months before onset of the rash. At this point of time, she went for this global BAT conference. She went for 12 days to West Papua, June 2023. So that was about a month before onset of the rash. This over here, she had the mammal watching. So she did a research of the mammals at the natural habitat. We managed to get a few, we managed to get the name of the animals that she investigated, research during that point of time. A bit of tongue twister. Vogelkop tree kangaroo, long-beaked echidna, Cincinnatus regius kingbird of paradise, Mosia nigerson dark-sheath-tailed bat, Dactylopsila palpator long-fingered trioc, and the Wagyu cuscus, Pilocuscus papunsis marsupial. Hopefully I do justice to the name of the animals. Right, okay, so not stopping there. So July, which is about 3 weeks before onset of the rash, she went to the local here, Pulau Dangli, Langkawi, for a National Geographic documentary filming on bats. Right, and she went to Nottingham, not Nottingham United Kingdom, it's a Nottingham University Semenye, July 2023. Again, some research on bats as well. She went to Pahang, Tengku Hassana Wildlife Reserve, Crow Wildlife Reserve in Pahang, with research on bats. I think this is the last one, 7th August 2023, at the northern region, the Telaga Tujuh, Langkawi. Also research on bats. So you can see how passionate she is in the bat research. Yeah? Right, okay. So with the extensive travel history and zoonotic animals contact, I think I sort of like answered your questions, right? Okay, so I just pass you the mic for you to go through the examination finding and blood investigation, and at any point you want to point out anything, then you are welcome to.
So on examination, she appeared of normal mentation. Her consciousness were normal. She did not appear to be ill-looking. There was presence of exophthalmos at the bedside. She appeared to be clinically euthyroid with diffuse neck goiter. She is normotensive and with a normal pulse rate. She's not appeared to be in tachycardia or bradycardia. She's afebrile. So lung examination was unremarkable. Cardiovascular and GIT system were unremarkable. There was no finding of any lymphadenopathies, and there was also no findings of any liver or spleen enlargement at the bedside. So investigation showed leukocytosis. Hemoglobin appears to be normal, but otherwise there was also presence of thrombocytosis. This could be pointing towards infective causes or any reactive causes. Other than that, her renal function appears to be normal with normal electrolyte level. Liver function appears to be normal as well with slight hypoalbuminemia. C-reactive protein is slightly raised at 3.13 milligram per liter. Procalcitonin level is low, not suggestive of any systemic bacterial infection at this point. But other than that, viral screening for any hepatitis markers were all non-reactive. Blood culture were unremarkable. ANA appears to be positive, but it's at a low titer of 1 in 100 speckle pattern. Rheumatoid factor was negative with also normal level of C3, C4, as well as negative for anti-double strand DNA.
All right. Okay. So great. So I think nothing much interesting except for the thrombocytosis, reactive, a bit of leukocytosis, and a bit of hypoalbuminemia. All right. Okay. So the chest X-ray. Do you want to comment anything since we talk about TB contact? Anything in particular?
So this is a chest radiograph of her. It is of presumably posterior to anterior view. There is no presence of any obvious cardiomegaly. There is slight increase of the perihilar markings. However, no obvious shadowing to suggest hilar adenopathies. There was no blunted of costophrenic angle to suggest any serositis or pleurisy. Other than that, no obvious lung opacities that can be seen to suggest consolidation on this chest radiograph.
Anything to suggest TB?
Not at this point, Izreena. Maybe the slight increase in perihilar markings would prompt me.
Okay, so the answer is no. All right, so there's no TB changes at all. All right, okay. So, okay, moving on to the interesting part of the day. So there's a reason why me and Dr. Mohan are here today. So looking at the rash. Okay, so these were the photos of the rash that we took prior to the procedure. So basically, before I ask you to describe the rash, so I think it's important to also emphasize that whenever you do a dermatological examination, it's not just by seeing 2D dimension, two dimension. It's very important to also examine feeling for the lesion, you basically feel for the temperature, feel for the induration, the depth of the skin lesion. All right, so because since Dr. Firhan has never examined or seen this patient before, so before he described the rash, so just to let you know that upon examination of the skin lesion, the skin lesions were tender on palpation and it's actually deep. You can feel it deep. Yeah. All right. Okay. So go to question 2. Please describe the rash and offer your differential diagnosis.
Can I see the photo of the... Okay, so there is presence of multiple erythematous rashes with indistinct border measuring about perhaps 3 to 5 centimeter in sizes. There is an induration surrounding the said rashes. Other than that, there's also presence of a violaceous hue or discoloration to the rash. And in one of the rashes at the cuff, there's also presence of with small ulceration at the base of the rash.
Okay. All right. Okay. Okay. Good. Thank you. So basically, just going through the rash, you can see there is a multiple erythematous, and also there's violaceous and dusky colored tender nodule mainly over the cuff. Mainly over the cuff and the lateral and medial cuff. And then I think you mentioned regarding the ulceration, it's actually just an erosion, it's not ulceration. Waalaikumsalam. All right. Okay. So just to highlight here that you can see there's a multiple erythematous and violaceous dusky erythematous nodule. Just to let you know that you can see the heterogeneity in terms of the color of the lesion, indicating that all of these lesions, they appear at different time point. So the most erythematous is the one that's more recent. So basically this is important because we will take biopsy from the fresh lesion. Okay, so your differential diagnosis?
So considering the following the rashes that were described, so the dermatological diagnosis that I would like to offer at the bedside, provisional would be erythema nodosum because of the nature of the tender nodule. Following this, I would like to offer differential diagnosis of first an insect bite, and then secondly, considering then followed by that, it could be an infectious process, or maybe furunculitis would be on the list. Other than that, moving to the extensive nature of traveling and involvement with the nature of patient, I would also like to consider diagnosis of maybe tuberculosis or leprosy. So maybe erythema nodosum leprosum, another name for cutaneous TB, but I can't recall at the top of my head right now.
Sure. Okay. Thank you very much, Dr. Firhan. So I think he basically got the important differential diagnosis already. So just to let you know, the differential diagnosis for this patient with tender erythematous nodule, the first one is your erythema nodosum. Right. As you can see the photo here, so with just by looking at it, you might think that this could just be a bruises or even cellulitis. But so you have to feel for it. When you feel, you can feel that it's indurated nodule or plaque. Erythema nodosum, usually it's symmetrical, anterration involvement, and not associated with atrophic scarring or ulceration. Erythema nodosum is not a full diagnosis. It has to be secondary to something. So there's exhaustive list of causes of erythema nodosum. I think I just highlight the important thing. Streptococcus being the commonest causes, infective causes. Not to forget, one of the systemic disease always asked, I think even at the undergrad level, sarcoidosis, 10 to 20% can get this erythema nodosum. And again, drugs. A lot of drugs can cause erythema nodosum. And not to forget your physiological condition, pregnancy. Just going through quickly, insect bite reaction. Usually insect bite reaction is very, very itchy, which is not present in this patient, and usually you will need to find hard for the insect bite marks if you're suspecting insect bite reaction. Furunculosis, that you mentioned, is a bacterial infection, is a inflammation of the hair follicles with secondary bacterial infection. So usually we need to look very closely, look for the hair follicles and pustules surrounding it. If you can't see it by your naked eye, you can use the moscope. Fixed drug eruption, so it's not a nodule, but from the photo you can see it's like hyperpigmented patch. So usually you suspect this when you have like recurrence of the rash, hyperpigmented patch or erythematous patch over the same site upon introduction of the similar drugs. Cutaneous vasculitis, mainly palpable purpura, but as you can see from the photo, because some of the later lesions, they tend to be purpuric, but you really need to feel for palpable purpura, which is pathognomonic of cutaneous vasculitis. I think he wanted to mention Bazin just now. It's erythema induratum of Bazin, which is a panicolitis, inflammation of subcutaneous tissue because of tuberculate reaction. So it's actually an immune reaction towards your tuberculous antigen. All right, so but usually you will have ulceration and scarring, which is not present in our case. Don't forget subcutaneous panicolitis T-cell lymphoma. It's rare. It's one of the rare variant of cutaneous T-cell lymphoma, of which we from the dermato side, we have to think of it if, especially if the patient is having this lipodystrophy upon recovery of the rash. And also lupus panicolitis or profundus, usually it's more like the indurated plaque nodule, and usually they will have the atrophic scar like this. All right, okay, so this is a very quick question. Name one single investigation, diagnostic investigation for the skin lesion.
Skin biopsy for histopathological examination.
Okay, great. Okay, so that's hinting towards our next panelist for today. Okay, so we proceeded with skin biopsy. We sent for histopathological examination as well as a few cultures, TB culture, fungal culture, TB PCR, CNS. All came back as negative. So we are honored to welcome our colleague from pathology department, Dr. Stephen Chew Jing Yang, who is a registrar in histopathology, to bring us through unleashing the secret beneath the skin. Right. Okay. So Dr. Stephen, without further ado, please join me in welcoming Dr. Stephen Chew.
So, hi, good morning, everyone. So today I'll be presenting the HP findings for this case, and I'll also talk briefly about panniculitis. Okay, for those who are not very familiar with what the skin looks like under the microscope, so I'm just going to have a quick run through. So as you all know, the skin is made of the epidermis, dermis, and subcutaneous tissue. So the top layer is the epidermis. This is a keratinizing stratified squamous epithelium divided into 4 layers. The corneum, granulosum, spinosum, and basally. And beneath it is the dermis, which is a dense connective tissue that supports the epidermis. So within the dermis, you'll see sweat glands, like this cluster of ducts here. And then you'll see hair follicles as well. And normally you would see sebaceous glands, but they're not in this picture. And directly beneath the dermis, you see the subcutaneous tissue. Okay, so the subcutaneous tissue is normally made out of mature adipocytes, fat cells. They are normally arranged in lobules, and you also normally see fibrous bands separating the lobules of adipocytes. And at this level, also you see blood vessels, lymphatics, and nerves. Okay, so what is panniculitis actually? So panniculitis is the inflammation of the subcutaneous adipose tissue. And we can divide them into 2 categories, septal and lobular panniculitis. So when the inflammation is mostly in the septum that divides the adipocyte lobules, we call them septal panniculitis. So there is erythema nodosomal. Okay. So in lobular panniculitis, you see the inflammation throughout the lobules of fat. And on top of that, you will normally see involvement of the septum to a certain level as well. Okay, so this is the skin biopsy that we received for this patient. So it's a 6 millimeter punch biopsy. It's got a good length, 7 millimeters in length. Okay, so even on this magnification, I'm sure all of you can tell that this is a very quite an abnormal looking skin biopsy. And most of the abnormality, if you notice, is in the subcutaneous level. So if you look at the subcutaneous level here, you notice that the lobules of adipocytes are no longer there. It is completely replaced by fibrosis and inflammation. And over here you can see some blood as well, a lot of hemorrhage and empty spaces. Okay, so let's go closer. All right, so this is the epidermis. Actually, the overlying epidermis looks relatively unremarkable. So from this biopsy, we don't actually see any ulcers or erosions. There's no blisters as well. There's no spongiotic eczematous change. And there's no interface activity as well at the dermal epithelial junction. We don't see any inflammation or vascular degeneration. The upper dermis also looks fairly okay, apart from some scattered chronic inflammatory cells. All right, so we go down deeper into the dermis. Okay, this is the lower dermis. Okay, so as you can see here, it looks rather busy. So let's have a look close up. So you can see here, there's a lot of fibrosis. And on top of the fibrosis, you get a lot of lymphohistiocytic infiltrates. So most of the lymphohistiocytic infiltrates are actually centered around vessels, so perivascular inflammation. And they are also centered around the annexal sweat glands as well. So these are the annexal sweat glands. These ones are the annexal sweat glands. Okay, and the background pinkish, more pinkish fibrous areas are the normal looking dermal connective tissue. Okay, so now we go down lower, somewhat to the subcutis. Okay, so as we zoom in the subcutaneous layers, you can see there's all these empty spaces with a lot of hemorrhage, and all these are actually inflammatory cells. Okay, so close up in the area of inflammation, and if you have a look at the type of population of the inflammatory cells, you can see bilobe and trilobe neutrophils mostly, and they're forming microabscesses. Okay, and this area here, you will see a lot of scattered pinkish cells. So all these cells are actually your eosinophils, normally bilobe with very dense eosinophilic granular body cytoplasm. And you will also see lots of vascular proliferation as well, like what you would see in granulation tissue formation. Okay, so now if you look at this part, the smaller picture on the left, okay, you see a lot of all these empty spaces, right? So when there's when the inflammation of the subcutaneous level, when it is severe enough, you will result in fat necrosis. So the fat cells start dying off. So when they start dying off, they swell up, and then they lose their nuclei, and the cellular membranes get disrupted. And then eventually the histiocytes will get recruited to digest all the released lipid from the dying fat cells. Okay, so some more pictures of fat necrosis here. And over here you see a lot of vascular proliferation with fibrosis and chronic inflammation. And to a certain extent, the septum is also involved. So there's fibrosis, scattered fibrosis with lots of inflammatory cells that you can see here. Okay. And some more pictures of fat necrosis. And over here you can see clusters of foamy histiocytes coming to digest the released lipid. So the type of inflammatory cells actually give us some information on whether this is an early lesion or whether it's a later lesion. And then in the much later stages, you see fibrosis. But in this picture, it's more of an acute on chronic picture. And also the type of inflammatory cells present will also give us a clue what the particular etiological group is. But it's not always possible and it requires clinical correlation. Okay. So normally the causes for a neutrophilic heavy lobular panicleitis, we always think of infection first, infective panicleitis. Commonly strep, but there's a long list as Dr. Izreena has presented earlier. The other two things to think about is pancreatic panicleitis. So if there's any history of pancreatitis or pancreatic carcinoma, so there's a release of pancreatic enzymes into the circulation, and it leads to fat necrosis in the subcutaneous layer. And normally we expect to see some amorphous basophilic granular debris like in this photo here. That's because of fat saponification. And alpha-1 antitrypsin deficiency, we don't see any specific findings. So normally we have to correlate clinically whether there's any pulmonary or liver involvement. And of course, nodular vasculitis or erythema induratum, they normally present as a mixed picture as well. So you normally see a mixture of neutrophils, eosinophils, and you also see granulomatous formation. So you see granulomas with variable degree of caseous necrosis, and they would also have features of vasculitis like fibrinoid necrosis, infiltration of neutrophils in the vessel wall, and RBC extravasation. And it's normally driven by TB as mentioned by Dr. Izreena earlier. Normally in a different organ, and then the antigen would circulate in the circulation, and it drives an immune response in the skin, in the fat. Okay, so non-TB causes no cardiac infection and drugs like propylthiouracil. Okay, so these are pictures that I fished online. It's not the pictures of the biopsy from a patient. So this is a picture of what nodular vasculitis looks like. So over here you can see a very vague looking nodule. Okay, so over here you can see aggregates of histiocytes, and surrounding the granuloma you can see fat necrosis like what we see in the photo earlier, and with some fibrosis. This is an example of what caseating necrosis would look like. All right. Okay, and in this photo, I just want to show you what vasculitis looks like histologically. So you can look at these vessels. Okay. So these are not normal vessels. So they're infiltrated by mostly chronic inflammatory cells, and you can see fibrinoid necrosis as well. Okay, and some RBC extravasation here. All right. So for this patient, we also did some Ziehl-Neelsen stain to look for AFB, and PAS and GMS normally to look for fungal organisms. So they were negative. Wharton steri we did after we found out about the serological investigation. Normally we use this for H. pylori in the stomach, but we can use them to look for spirituous as well, like syphilis or even Borrelia. Okay. So our diagnosis, we concluded that it is lobular panicleitis, suggestive of an infective cause. Okay. And I just want to briefly mention of what are the other causes of lobular panicleitis. So if the picture is predominantly of lymphocytes and plasma cells, we can think of lupus panicleitis or dermatomyositis related panicleitis. And if it's more granulomatous in nature, we think of things like Crohn's, posterior panicleitis, calciphylaxis, co-panicleitis, traumatic fat necrosis, and lipodermatosclerosis. Okay, that's all from me. Thank you.
Right, thank you very much to Dr. Stephen Chu for the insightful and informative session on the histopathological examination of this lady's skin biopsy. Right, okay, so moving back to our case. All right, so yeah, moving on to the next questions. So based on the HP finding, which is lobular paniclitis, I think Dr. Stephen already said that it's mostly is infective cause, and I think he sort of like hinted saying that we did a Warthin Starry stain after we got the diagnosis. So yeah, so any further investigation you would like to send at this juncture to clinch the diagnosis?
Well, considering the finding suggestive of lobular paniculatis, and then the fact that there was no finding of granuloma and all, this probably would narrow the diagnosis to infective cause. However, not likely to suggest tuberculosis and so on. So perhaps the next best investigation that I would like to send would be a list of a panel of serum tropical serological testing, or maybe PCR if available.
Okay, thank you, Dr. Firhan. So we actually proceeded with further serological testing. So just going through a little bit, we sent serum PCR for tropical fever, for chikungunya, West Nile virus, dengue, salmonella, rickettsia, leptospira, plasmodium, came back as negative. Yeah, so we sent this Borrelia burgdorferi, IgG, IgM. We sent to Hospital Sungai Buloh. We sent on the 13th of September. IgM was positive, but IgG was negative. About 14 days after that, 12 days after that, so both IgM and IgG came back as positive. Right, okay, so I'm not the expert to talk about the serological testing. So Alhamdulillah, today we are honored to actually welcome our distinguished speaker, respected speaker. She's Dr. Nur Hanani Ahmad. She's a clinical microbiologist, head of microbiology unit, pathology department from Hospital Sungai Buloh. So she'll bring us a wealth of expertise, especially in these vector-borne illnesses and serological testing. So hopefully we will get further clue regarding the case from Dr. Nur Hanani. So please join us in welcoming Dr. Nur Hanani, which is here at the Zoom link. Thank you.
Assalamualaikum and a very good morning. I hope you can see my slide. Can you hear my voice clearly?
Yes, Dr. Hanani. Yes.
Okay.
Thank you.
Sorry. Okay. So I'm Dr. Nur Hanani from Sungai Buloh Hospital. Thank you for the invitation to join the Grand CPC. So for my presentation, I will actually zoom into Borrelia burgdorferi, the microbiological investigations. So this is only a brief slide about Borrelia burgdorferi, because I believe maybe there will be another speaker will talk in detail about this. So why this brief slide is very important. If you want to send any microbiological investigation, you must know at least the class or the genus of the infection of the microorganism, because we can know what are the investigations that can be sent. And then Borrelia is transmitted to humans through the bite of infected heart, Izodis species. So Izodis species, it has multiple species, lots of species, depending on the geographical location. But what is common, it is found in forested areas. And so for Borrelia itself, it has got so many species, and it causes a variety of infection. For Lyme disease, it's caused by Borrelia burgdorferi. For relapsing fever, is caused by another Borrelia species, which is the Borrelia recurrentis. And the incubation period range from 3 days to 3 months, but the mean incubation period is between 2 to 3 weeks. Sorry. So as we all know, for microbiological investigations usually consist of microscopy, culture, serology, antigen testing, and also PCR. But as any other spirochetes infection, for example, syphilis, leptospirosis, microscopy and culture is not a sensitive test. Okay, so Borrelia is also another spirochete, so it's the same. Microscopy and culture is not sensitive. So that's why you have to know at least the class of the organism that you want to rule out. Okay, so and then another investigation, PCR testing, currently offered under research by IMR. However, it is only by consultation, and they only accept sample which is less than 10 days from the illness onset. For serology testing, you can send the sample to our lab in Hospital Sungai Buloh. Serologic testing is the principal means of laboratory diagnosis for Lyme disease. Okay, the interpretation of result depend on the timing of testing related to the symptom onset. The serodiagnosis is insensitive during the first several weeks of infection. Okay, so in the first several weeks of infection, the patient usually only 30% of patient has IgM positive, and then the IgM will seroconverted to positive about 2 to 4 weeks later, which is 65 to 75%. And then after 4 to 8 weeks, then we have a positive IgG. So this is actually an important graph to know about the antibody response following infection of Borrelia infection, Borrelia Burgdorferi. So if you look at this graph, the green graph shows the IgM when it starts to have seroconversion to IgM, and then for the red graph, it's showing the IgG. So if you look at this, the early infection, the early part of the infection, the first 10 days, the PCR is actually the best test to send. And if any infection, it has got antigen testing. Also, the earlier part, you can send for antigen. Okay, so if you look at this graph, the antibody, the IgM, we only develop after 7 days. And then the detection threshold is about 2 weeks, after 2 weeks of infection. And then the IgG, we only develop later on, and the detection level usually is after 4 weeks of infection. So this graph is from the Association of Public Health Laboratories. However, limitation of serology assay is actually the same. Like other serology assay, it can have false positive and false negative. For false positive, it can have cross-reactivity with other spirochetes infection, and also it can have false positive, for example, in cases like reactive arthritis and juvenile rheumatoid arthritis. And it also can give false negative if the testing is done too early, or if the infection is localized early infection. And of course, if patient has immunosuppression where they cannot mount the antibody response towards the infection, they can also have false negative results. Okay, so for Borrelia Burgdorferi or Lyme disease, many guidelines recommended two-tiered serology testing. So what is meant by two-tiered serology testing? So the first tier, traditionally, they suggested to do ELISA method for screening, and then the second tier proceed with confirmation test, which is the immunoblot. However, they noticed that not every lab can afford to do immunoblot because it is actually not a simple test and difficult to get the kit, and also it is a bit pricey. So some guidelines, they come up with an alternative algorithm, which is the modified two-tier testing. So if the first or the standard two-tier testing consists of EIA or ELISA, and then the second tier immunoblot, for modified two-tier testing, they use two different ELISA methods. Okay, the first tier use ELISA, and then the second tier use a different EIA or ELISA kit. Okay, so okay, I will brief you three of the guidelines. Okay, the first one is the Association of Public Health Laboratories. Okay, so using the standard two-tier testing, you send a sample and we will perform serology, IgG, IgM, ELISA. If the result is positive or equivocal, proceed with immunoblotting. And then the modified one, the sample, we do ELISA. If it's positive or unequivocal, we do a second immunoassay test. So these are both, but they still suggest for two-tier testing. Okay, for CDC, previously also the two-tier testing consists of first doing the ELISA, and then the second tier do the immunoblot. However, in 2019, they come out with recommendation where they actually recommended that serology assay that utilize EIA rather than Western immunoblot assay in a two-test format are acceptable alternative for the laboratory diagnosis of Lyme disease. So they also actually accept the alternative pathway where you use a second ELISA as a two-tiered testing. Yes, this is by NICE guideline, also the same. However, for NICE guideline, they only recommended to use first tier ELISA and second tier immunoblot, unlike CDC and also APHL. So what test is available in Hospital Sungai Buloh? So we offer ELISA, Borrelia burgdorferi, IgM antibody, and IgG antibody. The brand name is Novalisa. Turnaround time is 1 week. Okay. However, unfortunately, currently we only have first tier immunoassay available. Okay. So our recommendation is to send sample 3 to 4 weeks after symptoms onset. If suspicion remains high, to repeat after 2 to 4 weeks to look for seroconversion. So seroconversions means that maybe from antibody negative become antibody positive. Like in this case, the IgG, the first sample is negative and becomes positive 2 weeks later. We noticed that this is actually not the optimal algorithm. So currently we are in the process of evaluating Borrelia burgdorferi immunoblot, and we plan to start this two-tiered testing before end of this year. So in summary, from a microbiological part, the recommended to use to diagnose Lyme disease is to use two-tiered serologic testing. Like any other infection, when you want to send for serological test, priming matters, okay? And then the testing of patients who do not have symptoms typical of Lyme disease or who have not had the potential of exposure to ticks in the Lyme endemic region is strongly discouraged, because as it is important to correctly diagnose Lyme disease, it is also equally important to avoid misdiagnosis of Lyme disease and give unnecessary treatment when the true cause of illness is something else. Thank you.
All right. Okay. Thank you very much, Dr. Nur Hanani Ahmad, for the insightful talk, and I think it's very informative and it's something new to us clinicians. So without further ado, I would like to ask the final questions to Dr. Firhan before we invite our last panelist for today. So based on the positive serological finding and skin biopsy of lobular panicolitis, so what will be your final diagnosis for this patient?
So correlating all the findings together, the final diagnosis in this case will be systemic Lyme disease. And with regards to how would I manage this patient, I would like to refer to CDC, perhaps CDC guideline on management of Lyme management, and we'll start patient on tetracycline-based antibiotic of doxycycline, which I'll refer the exact dose and duration, which I believe should be perhaps 2 to 4 weeks, but I'm not entirely sure.
Okay, sure. Thank you very much, Dr. Firhan. So the diagnosis for this lady was disseminated Lyme disease, presented with arthritis and lobular panicolitis. So I think we would like to welcome now our colleague in infectious disease. So she's Dr. Ummu Afeera Zainul Abid. She's a fellow in infectious disease, also assistant professor and lecturer in Kuliah of Medicine, International Islamic University Malaysia, UIA. Dr. Ummu Afeera, indeed, she is one of the main person, backbone, apart from Prof. Patrick and the ID team in UKM, in unleashing the mystery and secret behind the skin lesion of our patient. So I think she's been like actually collaborating with the other team from IMR on Hospital Sungai Buloh before getting into the final diagnosis for this lady. So I think without further ado, I would like to welcome Dr. Ummu Afeera Zainul Abid to share her thoughts on this case. Thank you.
Okay, thank you, Dr. Izreena and all. So I'll be presenting the input. So before I start, I just give some overview. This is the top complaints in returning travelers leading to medical visit. For example, fever, diarrhea, dermatological disorders, and non-diarrheal GI disorders. For example, vomiting, abdominal pain. So some of the patients, they presented with all four, and some maybe only dermatological disorders and others. Okay. So how you approach when a patient presented with a fever or rash or anything in a returning traveler? So the first is actually you need to know what is the risk in the area travel. So this is some ideas. So the disease is actually, the etiology will be based according to the region traveled. And I love what just now Firhan answered. So when knowledge is whether you know it or you know where to find it. So you can always refer to few resources like CDC travel website, WHO websites, and there are also other websites that can help you to narrow down your diagnosis. So for example, the CDC travel website, you just need to key in your destination, and then they will come out with all the vaccines and the needs for them, and what is the disease endemic in that region. So one more important thing is actually don't always think about outside Malaysia. You must also remember your own country, because there are areas that is actually endemic for few diseases. So one of the, I think I met recently, one of a budding young scientist, Dr. Ahmad he did a very good research at Hospital Kuala Lumpur, where he collected nearly 70 patients with scrub typhus. So this is quite endemic at Hospital Kuala Lumpur. So whenever your patients travel to this area, you probably want to think about scrub typhus. And then once you know about the infection over the area traveled, then you can go actually what's the exposures, any prevention taken. So I think animal exposures is quite broad as well. So this is one of our patients recently at UIA. So this patient exposed to cats, and actually the skin cutaneous this is the cutaneous manifestation of Bartonellosis. And then the skin biopsy is actually the Watin starry stain mentioned by Dr. Stephen just now is actually positive in this case. And this is the results of the Bartonella serology. And I totally agree with Dr. Firhan as well when he mentioned about consume unpasteurized milk, because brucellosis and also Coxiella fever, your Q fever, Coxiella boniti, can also manifest it with a cutaneous manifestation. And in Pahang, one of my colleagues, Dr. Munira, also shared her case that the patient is actually positive for Coxiella boniti. And then it's actually you need to go through your signs, symptoms, and laboratory investigation. So they are actually a mixture. For example, this skin manifestation, it can also appear relatively in dengue as well. So they can actually mimic all your common endemic in Malaysia like dengue and chikungunya. And then the final is actually one more keywords that can narrow down your diagnosis is actually incubation period. So you can have a short incubation period, for example, rickettsia, your dengue, and then intermediate 8 to 30 days, you can have actually like malaria, and then your leptospirosis, typhoid fever. And then more than 30 days is actually like TB, your amoebic, and then leishmania. And this is also etiology of fever or rash manifestation according to the interval after travel. So then only probably you can get your diagnosis. So now we go through, zoom into our cases about Lyme disease. So I actually, my resources is from the CDC websites, and then IDSA guideline, and the last one is International Lyme and Associated Diseases Society. So IDSA actually published the last guideline is in 2020. And Lyme disease is actually very challenging. The testing sometimes can be confusing. It is a multi-system disease with variable presentation, different symptoms in different stages of disease, and many symptoms are non-specific and can co-infect with some overlapping features. And then, as mentioned by Dr. Hanani just now, it is caused by Borrelia species. And then what is this Borrelia? It's actually a spirochete, and then it appears like a spiral-shaped bacteria, and then it is a quite motile. So, like guideline always differ between US and Europe. So similarly in Lyme disease, some of the Borrelia is actually, they love US. So it's quite endemic. The Burden and also Borrelia mayoni is actually quite endemic in US. And in Europe and Asia, it's actually Borrelia garini and Borrelia afzeli. And for the transmission, this Lyme disease is actually zoonotic diseases. So you need to have a reservoir. So the reservoir usually so what is the meaning of reservoir? Sometimes it just in these animals, but it doesn't cause any harms and any symptoms to these animals. Then you have an infections towards your human, but how they transmit is actually they need a vector. So there are lots of vectors. So being an ID physician, I think we all have finished study all the human infection. So we thought we want to know more about the vectors pula. So but then I'm just joking, don't take this seriously, okay? So there are so many ticks outside there. So the commonest one for these diseases is actually Ixodes scapularis. But all this is actually, they can cause a variety of presentation and tick bite diseases like Borrelia burgdorferi is actually Lyme's. And then this is actually, I mentioned just now, Dr. Hafizi is actually interested to do research on Babesia as well. So there is actually correlations between all these because these diseases, these tick bite, they can have actually co-infection. So once it's transmitted, it must be, it can attach for a long times, and most transmission occurs after 36 hours of transmission. So this untreated Lyme disease can progress from early localized to early disseminated and also the late disseminated disease. So it is a multi-phase, multi-system disease. So what is early? So it's actually localized, only you have a erythema migrans. And then once you have a multiple, and then your patients can actually present with Bell's palsy, heart block or meningitis. And those that late manifestation is actually presented with arthritis. And I think our patient have multiple skin lesions, and then she presented with a debilitating joint pain. So this again is actually the manifestation of disseminated Lyme disease. You can have a cutaneous, neurologic, cardiac, and musculoskeletal. So 70% is actually a cutaneous manifestation and 30% is actually arthritis. And then the incubation period is 3 to 30 days, and the maximums, as mentioned by Dr. Hanani, it can goes up until 3 months. So 50% of the patients may not aware the prior tick bite. Okay, so what is erythema migrans? I think the dermatology parts will be explained further by Dr. Izreena, but then I just briefly tell you. So erythema migrans, the well described is actually the bullseye skin manifestation. It can round, erythematous, can be warm, rarely painful or itchy, and then it can expand slowly over multiple days. And then it can have a central clearing. So that's the reason they call it as a bullseye appearance. So the disease is actually manifested, most of the surveillance data, 95% in white individuals. But there is also 5% in Asian and darker skin manifestation, the black individuals. So I think it's a very difficult diagnosis in our Asian population and those in a black skin, darker skin, who have a darker skin, because I think it's one of the case described in House MD, season 4, episode 7, this young boy who should go for facial reconstruction for the facial deformity. He presented with heart block and joint pain. And finally, it is actually quite hidden over the hair area, the rash. So there is an article as well that mentioned how medical education is missing the bullseye because the darker skin tones have a slightly different manifestation of skin, not the typical bullseye described in the literature. So in a darker skin tones, it appeared darker expanding lesion, can be circular and can have central clearing. So the disease is actually mostly endemic at US. So one of the area is actually Maryland. So our patient actually traveled to Maryland, and then the peak season is actually around May and then to June, because these Ixodes scapularis nymphs are the most active during the late spring. So it's actually concurrent with our patients. She traveled to Baltimore, Maryland in May for the Global Union of Bat Diversity Network. So further history, actually, she had activities at the park there. So that's probably, but she's not aware about the tick bite. So there is no reported cases. I couldn't find any case reports about Lyme disease in Malaysia, but there is one study on seroprevalence of Borrelia burgdorferi among the orang asli in Malaysia. So they find and they concluded that this disease is currently under recognized. So under what circumstances that you should think about co-infection is in those patients with high-grade fever and laboratory abnormalities, then you think about anaplasma or Babesia microti co-infection. So this patient, because in Lyme disease, sometimes they are lack of fever. So if you have a persistent fever and lab abnormalities, so you need to suspect these diseases. So Babesia, they will have hemolytic anemia, thrombocytopenia, and then the typical blood filament. So in Lyme disease, you don't need to send blood film, but if your patient have thrombocytopenia, hemolytic anemia, you can send the blood films. So the descriptive is actually this tetrax appearance, okay? And then in this Babesia will have a very more sinister manifestations. They can have acute respiratory distress syndrome, splenic infarct, IHA, and other manifestation as well. Another differential co-infection is anaplasma. It also caused by the tick bite. Similarly, the patients presented with leukopenia, thrombocytopenia, and this is actually the blood film where they have a granulocytes contain intracytoplasmic inclusions. So agree with Firhan, if knowledge is whether you know it or you know where to find it. So you can always refer to the treatment, to the guidelines. So this is actually the treatment. So early localized disease, you can always give doxy, amox, or cefuroxime. And then early disseminated is actually doxycycline, ceftriaxone, and cefotaxime. And then the late disease, for example, in our patients, we can give doxycycline for nearly 1 month, or you give IV ceftriaxone for 28 days. So do additional antibiotics. I mean, after 28 days, you want to prolong the treatment. So no, there is a 4 double-blind study that mentioned no benefit of prolonging your antibiotics, and you have more risk of adverse events. So again, it's actually, we always talk in ID about prevention, intellectual solve problems, genius prevent them. So about the prevention of tick bites and tick-borne infections, please protect yourself from ticks. So you need to wear long sleeve pants and tuck pants into the socks. So to protect you from the tick bites. And then use repellents. This is actually mentioned in guideline. And whenever you have been bites, you can use the fine tweezers close to skin and you pull upwards steadily to remove the ticks. And then in endemic country, they actually send the tick bite for the species identification, but this is not done in Malaysia. None of us is actually expert in identifying the ticks. Okay, so who needs prophylaxis? If you know that the tick is actually Ixodes and those from a highly endemic area, and then the tick bite is actually attached more than 36 hours, and you've seen the patients within 72 hours. So you just need to give the patient doxycycline single dose. So that's all. Thanks to everyone who actually co-manage these patients. Thank you, Izreena.
All right. Okay. Thank you very much, Dr. Ummu Afeera. I think everyone has their eyes opened after listening to Dr. Afeera's talk. I think there's a lot of new things and new knowledge that we have learned from her. All right. So before we wrap up the session, just like a quickly run through, I just have 3 to 4 slides on the cutaneous manifestation of Lyme disease. So I think Dr. Afeera has made my life easier by explaining about erythema migrans earlier on. So there are 3 characteristic cutaneous manifestation of Lyme disease, which include erythema migrans, borrelial lymphocytoma, and acrodermatitis chronica atropicans, depending on the phase: acute, subacute, chronic. All right, so erythema migrans is a hallmark of early Lyme borreliosis, occurs in 90% of the case. So they are round to oval, sharply demarcated, red to bluish red skin lesion. Sorry. I just want to find the laser pointer. Yeah. Okay, so you can see it is well demarcated, unlike our case. Okay, it can be, homogeneous erythema. It can have a peripheral halo over here. So average incubation 2 weeks with a range of 3 to 180 days. So the typical sites around the band of large joints at your popliteal fossa, groin, armpit, rare in palms and sole. Solitary erythema migrans, they appear either in annular form with central clearing, target-like or bullseye appearance, or homogeneous erythema like this one. Okay, so the second manifestation, Borrelia lymphocytoma, which is a B-cell pseudolymphoma, occurs in response to the presence of Borrelia burgdorferi antigens in the skin. So it's actually an immune reaction towards the antigen. It's called pseudolymphoma. It's not cancerous. It's pseudolymphoma. So it's an immune reaction towards the antigens. So around 5% of all dermatoborreliosis, they are more predominant in children. So usually they will have this solitary bluish or purplish nodular lesion. So usually in children, they appear in the pinna, can occur at the areola in adult, and also they can also appear at the anterior part of the scrotum. Okay, last one, the manifestation of Lyme disease cutaneously is acrodermatitis chronica atropicans. So usually in your dermato punya rash, usually the name can actually suggest already what is it. So acrodermatitis, acral, your extremities, your feet, your hand, dermatitis, inflammation of the skin. Chronica suggests the chronicity of the skin lesion. Atropicans is atrophy, epidermal atrophy or dermal atrophy. Right, so ACA is the cutaneous expression of late-stage Lyme borreliosis in Europe. In the US, only a small number of cases have been described, which may be explained by the almost exclusive causation of ACA by Borrelia afzelii, which is a subtype of antigen that is not found in America, so usually in Europe. If you still remember Dr. Ummu Afeera's slides, so the afzelii is not common in US, it's more common in Europe. So it's more predominant in elderly. So usually they have this bluish red discoloration and doffy swelling of the skin without sharp borders like your erythema migrans. Subsequently, atropicans, the skin becomes gradually thin and wrinkled to the loss of epidermal and dermal structures. So they can also have these prominent blood vessels appearing as the telangiectasia, and also this looks like varicose vein as well. All right, okay. Sometimes they can have like joint subluxation at the area involved. You can see the area involved of the extremities, acral. All right, so panniculitis, how about our case? Yeah? So she presented with erythema nodosum with histological diagnosis of lobular panniculitis. So indeed, panniculitis is a rare cutaneous manifestation that has been increasingly reported in Lyme patients, which develops after dissemination of the spirochetes. So the panniculitis is basically your immune reaction towards the Borrelia burgdorferi. Lyme disease is rare in Malaysia. Erythema nodosum with panniculitis is even rarer. So this is the rare of the rare. Yeah, okay. All right, so progress of our patient. So alhamdulillah, joint pain already resolved and rash completely flattened with post-inflammatory hyperpigmentation, and she successfully returned to her daily work and activities. Yeah, all right, okay. So it's a good news at the end. All right, so a bit of take-home message. So I think we saved the best for last. We have Dr. Mohan Arumugam, our consultant dermatology and also the coordinator of Advanced Master of Dermatology, Faculty of Medicine, Hospital Chancellor Tuanku Musris, UKM. So no need for the introduction. I would like to please give a big round of applause to Dr. Mohan Arumugam. Thank you.
So thank you, Dr. Izreena. So just to recap this case, right? So traditionally, Lyme's disease is transmitted by ticks. The common history that we get is patient visited a park, usually in the northern parts of America, and was bitten by a tick, or sometimes they don't recollect being bitten by a tick. Okay, and these ticks are usually found on deers in these parks. But I think there's now growing evidence that suggesting that bats and their associated ticks may play a part in disseminating Borrelia. So I think this is, since our patient here, she had widely traveled and had been working with bats, right? So I think this is something that is worth looking at in the future. And other point that I would like to bring up is that the first rash that appeared over the upper limbs. So by the time the patient got to us, you notice we didn't show any pictures of the upper limbs because the rash had resolved. So that could have been the erythema migrans. And usually erythema migrans, like as Dr. Ummu said, it can occur anytime 3 to 30 days after being exposed to the bacteria, Borrelia. And it usually resolves after about 3 weeks. So it's possible that the first rash that the patient presented with on the upper limbs could have been erythema migrans. Okay, and the final point I'd like to bring up is that when she presented with erythema nodosum, which is a panicolitis, right, inflammation of the fat layer, when they sent off the tissue biopsy, they also sent it off for cultures, and it came back negative. And of course, when the histopathologist did the stains, as Dr. Stephen mentioned, there were no evidence of infection. So this actually suggests that this panicolitis is not directly involved with the infection, but rather an immune reaction towards the infection. Okay, so these are the 3 points that I would like to bring up. So in summary, this case actually exemplifies the synergy of various disciplines of medicine coming together to give this patient the best care. Right. So with that, I'd like to thank you. If there are any questions, then we open it up to the panelists.